Hi everyone. We are going to be talking about schizophrenia and other psychotic disorders. And starting here with nursing assessment, diagnosis, and outcome. Your second lecture is going to then start with interventions and continue on from there. The first thing we're going to be talking about is assessment, and really we have already covered all of the subjective and objective information assessment when we talked at the beginning of the unit about signs and symptoms of a person with either schizophrenia or a psychotic disorder. But we can break it down into subjective and objective data. So subjective data, that would include the perceptual changes that are happening in this person's senses. So illusions, we can ask them, what are they seeing? What are they hearing? With hallucinations, okay, I want you to look at page 3, actually that should be page 346, I'm sorry, that talks about assessing the client for hallucinations. There's a box towards the end of the page that talks about that, so I really want you to look at that. Probably one of the best ways to assess for hallucinations is to ask the client, are you hearing anything or seeing anything that other people aren't seeing? And this has proven to be a pretty good question, that they can understand what you're asking and able to answer that. Now, most patients will tell you, the truth, but then there will be those patients who are somewhat paranoid, maybe delusional, who may not exactly tell you the truth. So you always have to be assessing for how guarded they seem. Are they hesitant to answer you? That sort of thing. Other ways that we can assess for a hallucinating client that might probably actually fit more into the objective data would be if possibly the patient has a hands over their ears, if they're smiling or laughing inappropriately, either during conversation with you or if they're sitting possibly by themselves or with a group of people and they're smiling and laughing inappropriately. If they have difficulty following the conversation, that might mean that they are preoccupied and maybe attending to internal stimuli such as listening to voices. If you see them looking at the ceiling a lot or looking around the room, those might also be symptoms of hallucinations. One thing I want to mention because we're talking about hallucinations is to remind you about assessing for command hallucinations. So the person may say that they're hearing voices. Then the next question would be, are the voices, what are the voices telling you, or what are the voices of? And they can tell you whatever that is. But if they're saying, well, voices are telling me to do things, you need to ask them, what are the voices telling you to do? So we can assess if that's posing a risk for a danger to themselves or danger to other people. So then moving on to objective data. Again, we've covered all these. We want to be, looking for positive and negative symptoms. And to remember that we would gather most of this data by, doing our mental status exam, reviewing the mental status exam, and gathering all that information. We definitely want to look for altered thought and altered expression. And example of this would be if they have any type of thought disorganization, and we covered many of those thought disorganization types, such as thought blocking, back in earlier parts of the outline, so you may need to go back and review those. We are also looking at rate, tone, loudness of speech, if they're continuing to talk, not stopping at all, if they're jumping from topic to topic, or is their speech very slow and hesitant. And then we'd always test them for abstract thinking and their judgment. Emotional response, we're talking about their affect. Is it blunted, flat? Is it incongruent with their mood? Motor behavior changes, again, we've talked about all this. Their behavior, is their behavior very disorganized? They're moving around aimlessly, easily disruptive, no goal? Are they catatonic? Do they have that hyperactive catatonic, or do they have more of the waxy flexibility, the posturing? We also want to be assessing what is their level of functioning. And for example, especially before and after the onset of schizophrenia or the psychotic episode, what could they do before and now? What is their ability to function? We're also looking at role responsibilities here, as well as taking care of their job, that sort of thing. Drug use, very important that we assess for this. We want to be, really identifying, is this a drug withdrawal that's going on? Is this a drug-induced psychosis? We've talked a little bit about that, especially in my clinical, that a new type of synthetic marijuana called wax. We've seen 2 or 3 people now who have come into the hospital with a psychotic episode after smoking this wax. We would can attain that drug use by getting blood levels, also collecting urine for drugs of abuse, also collecting a drug history, and many times we may need to get that from the family. We also want to be looking at family history. First of all, maybe what is the family, has other families had issues with psychosis, other types of psychiatric illnesses, but also a history of the family. How cohesive is the family? What is the communication style in the family? Is there a lot of negativity in the family? A lot of critical or overprotectiveness in the family? Those are other things we'd want to assess here. The environment, we want to look at, how supportive of an environment are they in? Or do they have no support at all? Maybe they have no families or friends. Services, we also want to look at what services are they hooked into. Do they have a caseworker? Or have they never been to a psychiatrist or a family doctor, forever? Or maybe they haven't been to somebody for 2 or 3 years. Do they have a psychiatrist? Are they hooked up with any type of counseling services? What is their housing? Okay, are they in supervised housing? Or are they living at home? That sort of thing. So all those things that would fall under that environment are important to assess. So then that leads us into nursing diagnosis. We want to make sure that we're looking, in order to determine the nursing diagnoses, really be looking at the patient's strengths and their deficits. This will really help us to plan. We're going to be looking at any issues that have to do with the person's activity, their cognition, their emotion, their interpersonal process with others, and their perception. Okay, those perceptual disturbances. Now, what I would like you to do is, when you're studying, is I'd like you to be able to take these nursing diagnoses that I have listed here, and these are also in your book, and to be able to tell me, why would a person with psychosis or schizophrenia, why would they have this impaired communication? What might that look like? Okay, for a typical person with a psychotic disorder or schizophrenia, and be able to identify that. So really what we're looking at here is a lot of the signs and symptoms that might go with these nursing diagnoses. So first of all, impaired communication. Okay, so do they have is their verbal communication impaired? Many people who have disorganized thoughts, such as flight of ideas, word salad, blocking, those types of things, that is going to make them have a difficult time communicating their needs, communicating their feelings. So that very well could be the nursing diagnosis there. Take a look and review the characteristics of speech on table 16.3. Impaired communication could also be nonverbals. If the person is unable to has a very flat affect and is not able to show any emotion, that could be impact their communication. The next nursing diagnosis, self-care deficits. If the person is neglecting their ADLs, not eating properly, not bathing, not taking care of other ADLs, this can definitely pose a health risk, such as like I said, inadequate hygiene. If they're not dressed for the season, if they have inappropriate dress, those are not eating properly, those could all fall in that self-care deficit. Social isolation. Many times people with schizophrenia have a lot of anxiety about relating to other people. They sometimes can sense that people relate to them differently, or people are judging them, or thinking that there might be something wrong for them. And when they become aware of this possibly, or with this anxiety, many times they will choose to withdraw or become isolated. Also, if a person is having some of those negative symptoms, such as avolition or anhedonia, sometimes that causes a person to become socially isolated. Also be sensitive to how long a person with schizophrenia or psychosis can be in a conversation. Many times they can only be in a conversation, a one-on-one conversation, for say 5 to 10 minutes. And so it may not be realistic for you to have a 1 hour long conversation with them because of either their thought process or their anxiety, and so they have that social isolation. Decisional conflict. This is due to some of those negative symptoms that we talked about, possibly the ambivalence or apathy. It may be very difficult for them to make a decision about medications or housing. It also may be if they have a very disorganized thought process, if they aren't thinking logically, if they have delusions, that sort of thing. It's going to be difficult for them to make decisions and to make sound decisions as well. So we need to be aware of what their thought process is before we're asking them to make a lot of decisions. And some decisions may need to be postponed until they are back to logical, goal-directed thought process. Sensory and perceptual alterations. This would include an alteration in all those 5 senses that we talked about, that with the hallucinations. This could also include illusions. This could also include body image disturbance. Sometimes people with schizophrenia will have odd ideas about their body and almost see their body as an illusion, like my arm melds in. If I'm resting my hand on a desk, I can't really tell where my hand ends and the desk begins. Or if they're looking at their foot on the floor, I can't really tell where my feet end and now the ground starts, and where the carpet starts. So it's a very kind of odd type of body image disturbance. Next, excess fluid volume. Many people with schizophrenia have what we call polydipsia, or excess thirst, and they have great tendency to want to drink, and it's very abnormal and poses a problem of drinking all the time, and they become what we call water intoxicated. And once the person has too much water on board, in their body, they can run into a lot of problems: hyponatremia, confusion, disorientation, and eventually it could lead to death. So we need to be very careful with that and making sure that we're assessing that. And we'll talk about signs and about interventions that we need to do with that in a little bit. Sorry, I forgot to change the slide now to excess fluid volume. Many times this excess fluid volume only occurs in long-term patients, usually like in institutions and those types of situations. And we'll talk a little bit more about that in class. Disturbed thought process is another nursing diagnosis. What I have found out is that our psych book includes that disturbed thought process as a nursing diagnosis. If you go to your Dungee's book, the more recent list for NANDA and the new nursing diagnoses don't include disturbed thought process, but your book still uses it, and so you may use that on care plans as far as I'm concerned. And I really do think it is a very good way to describe what's going on with people who have disorders in their thinking. Okay, so we're still using it here because our book is using it. So what falls under disturbed thought process? Those persons' delusions. And often we see that those delusions reflect fear, personal inadequacy. And because of those delusions, they often have feel afraid, have aggressive feelings, or those aggressive feelings might be projected onto other people. Magical thinking is another type of disorganized thinking or disturbed thought process. Sometimes people will believe that if they wish something, then it's going to happen. Okay? And then we've talked about some of these others: thought insertion, withdrawal, broadcasting. Make sure you understand what all of those types of symptoms are if you need to look those up, but those fall under that disturbed thought process. Altered emotional response, that's the person's affect. We kind of talked about that up in nonverbal communication, but we can also have the diagnosis of altered emotional response. if they just have a flat affect, don't have the normal response. If they have a lot of anhedonia, that could again fall under that altered emotional response. The next one on here is dysfunctional family process. And this basically, how is the family functioning? Is there issues going on in their communication problem? You know that anytime a family has a person in there that has a diagnosis of, or gets a diagnosis of for a chronic illness, there's a lot of upheaval that may occur in that family. Possible changing of roles, changes in income, changes in housing, all of those types of things. And so that can really throw the family into a dysfunctional process. So we want to always be assessing this. And we also know that a dysfunctional family or chaotic family can also add stress to the person who has schizophrenia, and that sets them up for possibility of more exacerbations, relapses. So we want to know about that. Again, also be assess or a family that has a lot of over-involvement or a lot of negative emotions. We want to be aware of that, and it could fall under this dysfunctional family process. That also would include the interrupted family process. So make sure you look at both of those. And the last, another diagnosis, risk for violence to self or to others. Okay, risk for violence, self and others. I have down here page 756 to 770, and I want to refer you to chapter 35 that actually talks about anger management and intervention in the psychiatric population. Your book didn't include this diagnosis, but I want to make sure that we put this in our outline just because it can be an issue. Many times if patients are very paranoid or hearing command hallucinations and a variety of other symptoms that may put them at risk for violence. And so it's very important for us to be aware of that. And we all know that risk for that violence or danger to themselves or others is always going to be a top priority there. So just look at those diagnoses in that chapter. The other last diagnosis is anxiety. And the only thing I really want to say about this, your book talks about it, so take a look at that. But that anytime a person has, again, having those positive symptoms, that can create a lot of anxiety in them. If you can imagine feeling like somebody is following you, can read your mind, somebody is after you, hearing voices and becoming very, very confused, that can create a lot of anxiety. All right, so all of that can feed into that anxiety. The next part of the lecture is the outcomes, and I've kind of created these outcomes on my own because I just want to make sure that we all understand what's going to be happening in these individuals. And I just have it divided into acute psychotic episode, and then once the acute phase is over, what do we want, what do we hope to accomplish, or what are the goals? So when there's an acute psychotic episode, when the person is actually having those positive symptoms, okay, one of the first things that we want to do is they're usually going to be in a inpatient psychiatric facility, especially if they're a danger to themselves or to somebody else. And we want to, first of all, stabilize that process and help them get back to reality orientation. So that's one of our outcomes that we want to achieve. The next thing that and we'll talk about interventions for that in further on down the line, but we basically the best way that we can stabilize that thought process is through medication, getting that a typical or atypical antipsychotic to reorganize or stabilize that dopamine and serotonin, so that they get back to reality orientation and a logical thought process. The next outcome that we want to maintain, and these are pretty much simultaneous. We don't want to necessarily do one first and the other, but they go on at the same time. Maintain the person's safety and the unit's safety, and we do this through that therapeutic milieu where we focus on the safety of the unit, the environmental safety, and that would include the doors, what's in the bathrooms, the pull-down hooks, the plastic glass that's everywhere instead of real glass, all those things that we've talked about in the previous units. Maintain that safety. Also keeping a low stimuli for those individuals, because again, sometimes the way that they're perceiving their perceptual interpretations are very overstimulating and makes it more confusing for them, so we want to keep a low stimuli. And then the next outcome falls under once the acute phase is over. And once the acute phase is over, usually the person is able to be transferred to a less restricted unit. It might be a more open unit where they can go out on passes, they can come back in, a lot less restrictions. And here we want them to develop an ability to live independently and successfully in the community. We want them to, and this may require a lot of follow-up care for them. It may involve the patient and family working together, receiving community services. And then the next outcome is that we want to maximize their functioning, whatever that would mean for them. So if they can go back to school, okay, or if they can hold a job, that would be great. If we possibly think that they need to have a less stressful job but could still work full time, again, that's maximizing that functioning. It may be that they can only work part-time. It may be that they choose not to work at all but are doing volunteer work. So whatever that maximum functioning is for that person. We need to really make sure that when we're setting these goals for them, once the acute phase is over, that we're setting realistic goals. And it might be that we are starting with really, small, short-term goals and achieving those one at a time. Okay, so little changes over time, not, huge changes. All right, and that's the end of this lecture 1.